This is the audio lecture for Chapter 17, Labor and Birth Complications. When complications arise during labor and birth, risk for perinatal morbidity and mortality increases. Some complications are anticipated, especially if the woman is identified to be at high risk during the antepartum period. Other complications are unexpected or unforeseen. It is crucial for nurses to understand the normal birth process to prevent and detect deviations from normal labor and birth and to promptly implement nursing measures when complications arise. Optimal care of the laboring woman, fetus, and family experiencing complications is possibly only when the nurse and other members of the obstetric team use their knowledge and skills in a concerted effort to provide competent and compassionate care. This lecture focuses on the problems of preterm labor and birth, postterm pregnancy, dystocia, obesity, and obstetric emergencies. Preterm labor is defined as cervical change and uterine contractions occurring between 20 and 37 weeks of pregnancy. Preterm birth is any birth that occurs before the completion of 37 weeks of pregnancy, regardless of birth weight. Complications related to preterm birth account for more newborn and infant deaths than any other cause. Preterm birth and prematurity describes the length of gestation regardless of the infant's birth weight. Preterm birth is more dangerous to the infant because of the decreased length of time in utero correlates with immaturity of body systems. Low birth weight describes only birth weight. So low birth weight is a weight of 2,500 grams or less. Intrauterine growth retardation or restriction is inadequate fetal growth. It doesn't mean that they come out weighing less. It just means that they're not growing at the appropriate size for their gestational age. There are two categories of preterm labor and birth. These are the spontaneous versus the indicated preterm birth. Spontaneous preterm birth occurs after an early initiation of the labor process and comprises nearly 75% of all preterm births in the United States. Conditions such as preterm labor with intact membranes, preterm premature rupture of membranes, you'll hear PPROM, cervical insufficiency or amnionitis often results in preterm birth. Indicated preterm birth occurs as a means to resolve maternal or fetal risk related to continuing the pregnancy. About 25% of all preterm births in the United States are indicated because of medical or obstetric conditions that affect the mother, the fetus, or both. An increase in the number of indicated preterm births between 34 and 36 weeks of gestation accounts for much of the recent rise in late preterm births. In your textbook, box 17-1 lists some common causes of indicated preterm births, so please make sure you look over that box. The major risk factors for spontaneous preterm births are listed on this slide and also in box 17-2 in your textbook. Poverty, lack of education, living in a disadvantaged neighborhood, state, or region, and lack of access to prenatal care also have been identified as risk factors. In addition, the risk for preterm birth appears to be genetically related. For example, women who were themselves born prematurely have an increased risk for giving birth prematurely. Therefore, it is important that all women be educated about prematurity not only in early pregnancy but also in the preconception period. Predicting spontaneous preterm labor and birth. We're going to talk a little bit about the fetal fibronectin test. Fetal fibronectin is a biochemical marker. It has been studied extensively and is marketed in the United States as a diagnostic test for preterm labor. It is a glycoprotein glue found in plasma and produced during fetal life. Fetal fibronectin normally appears in cervical and vaginal secretions early in pregnancy and then again in late pregnancy. The test is performed by collecting fluid from the woman's vagina using a swab through a speculum exam. The presence of fetal fibronectin during the late second and early third trimesters of pregnancy may be related to placental inflammation, which is thought to be one of the causes of spontaneous preterm labor. Now, when we're talking about the fetal fibronectin test, usually the results are either going to be positive or negative. Now, if our fetal fibronectin test comes back negative, we can for sure say that this person or woman is not going to go into preterm labor within a 2-week period. Now, so if it's negative, we know that it's really negative. Now, if the fetal fibronectin comes back positive, we don't automatically say, oh, she's going to go into preterm labor. We look at other circumstances. Is she contracting? Is her cervical length starting to shorten? Is her cervix starting to dilate or efface? Is her water broken? All of these things that we think about when we think of labor. Now, there are a lot of things that will also cause the fetal fibronectin to give us a false positive. If there's any blood in the vagina, the test can come back positive. If the woman has had intercourse within the last 24 hours, it can also come back positive. And if the woman has had a cervical exam, a manual cervical exam by her physician or a labor and delivery nurse or a midwife, that can also cause the test to be positive. So when we're doing a fetal fibronectin, we want to make sure that there has been nothing in the vagina for a 24-hour period, and we usually do a speculum exam to collect the sample. Now, cervical length. This is another possible predictor of preterm labor. Changes in cervical length occur before uterine activity, so cervical measurement can identify women in whom the labor process has begun. Women whose cervical length is greater than 30 millimeters or 3 centimeters are unlikely to give birth prematurely, even if they have symptoms of preterm labor. Now, typically, like I said earlier in class, the normal cervical length is anywhere between 3 to 4 centimeters in length, and we really start to get concerned when the patient's cervical length becomes 2 or less. Causes of spontaneous preterm labor and birth. Infection is definitely associated with preterm labor. Women in spontaneous preterm labor with intact membranes commonly have organisms that are normally found in the lower genital tract present in their amniotic fluid, placenta, and membranes. Clinical and laboratory evidence of infection are more common when birth occurs earlier than 30 to 32 weeks of gestation rather than closer to term. Urinary tract and intra-abdominal infections have also been related to preterm birth. That's why I said any infection during pregnancy we take very seriously and we treat them right away. Another proposed cause of preterm labor and birth is bleeding at the site of placental implantation in the uterus in the first or second trimester of pregnancy. The resulting uteroplacental ischemia or hemorrhage at the decidual layer of the placenta may somehow activate the preterm labor process. And in some women, we've started doing weekly shots of progesterone. So we know that progesterone is the hormone that maintains the pregnancy. Recurrent preterm birth can be prevented in some women by administering prophylactic progesterone. Whether it's an injection or suppository, we know that progesterone maintains the pregnancy. Prevention of preterm labor. Because all pregnant women must be considered at risk for preterm labor, nursing assessment for factors that contribute to this risk begins early in pregnancy and continues throughout the prenatal period. The onset of preterm labor is often insidious and can be easily mistaken for normal discomforts of pregnancies. So, as part of the prevention, we want to do preventative strategies to address risk factors. Definitely education about early symptoms of preterm labor, health promotion and disease prevention. We need to offer all of our women in their childbearing years preconception counseling, especially if they're thinking about becoming pregnant. We can institute interventions to prevent spontaneous preterm birth. There's definitely more research is needed because we still really don't know what causes preterm labor. We have a lot of hypotheses, but we really don't know what triggers the body to go into preterm labor. We also need to teach our pregnant women what to do if symptoms occur. Many women may ignore symptoms because of ignorance regarding the significance, or they believe that symptoms are expected through in pregnancy. A lot of women, especially your women who've had multiple births, whether it's their second, third, fourth, or fifth pregnancy, they may ignore the signs and go, "Oh, that's not the real thing yet. They're just Braxton Hicks," and they may disregard those Braxton Hicks contractions, and they really could be going into a preterm labor. So we must teach the women not to ignore those signs and symptoms, but to at least call the physician and talk to their physician or their midwife to see if they really need to come into the hospital to be evaluated. Early recognition and diagnosis. Although preterm birth often is not preventable, early recognition of preterm labor is still essential to implement interventions that have been demonstrated to reduce neonatal and infant morbidity and mortality. These interventions include A. Transferring the mother before birth to a hospital equipped to care for her preterm infant. B. Giving antibiotics during labor to prevent neonatal group beta strep infection. C. Administering glucocorticoids to women in labor to prevent or reduce neonatal and infant morbidity and mortality from health problems, including respiratory distress syndrome, intraventricular hemorrhage, and necrotizing enterocolitis. And we'll talk about necrotizing enterocolitis when we talk about the high-risk newborn. D. Administering magnesium sulfate to women giving birth before 32 weeks of gestation to reduce the incidence of cerebral palsy in their infants. Because more than half of preterm births occur in women without obvious risk factors, it is essential that all pregnant women be taught the symptoms of preterm labor. And those symptoms are listed in box 17-3 in your textbook. The diagnosis of preterm labor is based on 3 major diagnostic criteria. They have to be at a gestational age between 20 and 37 weeks because we do consider 38 weeks to be term. So anything less than 38 weeks is considered preterm. Uterine activity and progressive cervical change. So just like my definition for labor, we have that same definition. The woman is going to experience increase in frequency, duration, and intensity of her contractions, along with cervical change. And usually if they get to a dilation of 2 centimeters or greater, or more than 80% efface, we are pretty sure that they are probably going into preterm labor. Lifestyle modifications. Activity restrictions, including bed rest and limited work, is a commonly prescribed intervention for the prevention of preterm birth. Restriction of sexual activity is frequently recommended for women at risk for preterm birth. Home care of the woman at risk for preterm birth is still challenging for the nurse, who must assist the woman and her family in dealing with the many difficulties faced by families when one member is unable to fill their usual role or responsibilities. Now, I know your book says that there's not a lot of research that supports the bed rest and the sexual activity restriction, and your book says that, you know what, it actually may cause more harm than good, because if the woman is quote unquote on bed rest, all of the things that go along with immobility, such as blood clots, things like that, she's at greater risk for that. But working in the maternity unit, I have seen women who have been on bed rest and they have kept those babies, or the baby in utero for at least a good month and some longer. So we always say anytime inside the uterus is better than outside the uterus. So if we can get the mom to keep that pregnancy for 2, 3, 4 plus weeks, we are doing good, because that gives us the opportunity to give that baby the glucocorticoids to help with the lung development and surfactant production. So now we have this mom or this woman who's in preterm labor. What kind of medications are we going to use to stop the preterm labor? So the Tocolytics, those are medications given to arrest labor after uterine contractions and cervical change have occurred. The goal of the tocolytics is to delay birth long enough to afford the opportunity to begin administering antenatal glucocorticoids, such as your betamethasone, and your book also talks about dexamethasone, and usually betamethasone is our drug of choice, but if we run out of betamethasone or celestone, we have the dexamethasone. And I remember a few years back there was a nationwide shortage of betamethasone, so we were using dexamethasone for our glucocorticoids. The disadvantage of the dexamethasone is it's required 4 IM doses, and your betamethasone we only require, it's only 2 doses that we have to give the mom. No tocolytic has been shown to reduce the rate of preterm birth. Rather, the rationale for giving these medications is to delay birth long enough to allow time for maternal transport and for corticosteroids to reach maximum benefit to reduce neonatal morbidity and mortality. Maternal and fetal contraindications to tocolytic therapy are listed in box 17-5 in your textbook. And box 17-6 describes the nursing care for women receiving tocolytic therapy. So make sure you read over those boxes. Now, the main tocolytics that we use in labor and delivery, magnesium sulfate is that's the big guns. That's our biggest and baddest medication that we have. And we talked extensively about magnesium sulfate when we talked about using it for preeclampsia and eclampsia, but we also use magnesium sulfate for preterm labor. It's also a tocolytic because it's a smooth muscle relaxer, and our uterus is a smooth muscle. So we also will put moms in preterm labor on magnesium sulfate. So the same care that we give to the moms on mag sulfate that have preeclampsia, we almost do the same thing with our moms that have preterm labor and they're on mag sulfate. The only thing is we don't have to worry about the mom having a seizure and becoming eclamptic, because she's not on the magnesium for a hypertensive issue. She's on the magnesium for a preterm labor. But just like the moms who are on mag for hypertensive problems, we do the same monitoring every hour. We're doing lung sounds, vital signs, clonus, DTRs. We're looking for signs of mag toxicity on these moms. We're checking magnesium levels. We're making sure that their input and output are equal. So whatever I'm putting in, she's putting back out. Um, and we know that in case she does become mag toxic and she stops breathing on us, we have calcium gluconate to reverse those effects. Another medication that we use quite a bit is terbutaline or breathine. And this is a picture of the terbutaline. Basically, the mom can take the terbutaline PO, sub Q or IV. The thing with terbutaline is we have to be careful because it causes the mom's pulse rate to increase, and it also causes the mom to have the jitters or they shake a lot. So one of the things when we're using breathing, we always check the pulse first, and if the maternal pulse is 120 or greater, we're going to hold the medication. Nifedipine or Procardia is another medication that we use. Usually they take this PO, and usually they take it about every 6 hours. Typically, once they've been on magnesium sulfate for a 24-hour period, we'll take them off the magnesium and then we'll start them on the Procardia. Um, the thing you have to watch out with the Procardia is for hypotension. So typically when we first start a mom on Procardia, we let her know you may want to stay in bed right after you take it. You may be dizzy. Make sure you dangle on the side of the bed before you get up so that you won't fall. Another medication that we use early for preterm labor is indomethacin. Indomethacin is an NSAID, and usually we use the indomethacin early. So like a mom who's going to get a cerclage, we'll put her on some indomethacin so that she won't start contracting after her cerclage is placed. Typically, we don't keep moms on indomethacin past 20 to 22 weeks. One of the side effects of the indomethacin is that it can cause early closure of the ductus arteriosus. And I want you guys to look up the ductus arteriosus and see why that we don't want that to close while the baby's in utero, because that's one of the ducts that close once the baby is born. Promotion of fetal lung maturity. Antenatal glucocorticoids are given as intramuscular injections to the mother to accelerate fetal lung maturity by stimulating fetal surfactant production. They are now considered one of the most effective and cost-efficient interventions for preventing morbidity and mortality associated with preterm labor. Antenatal glucocorticoids have been shown to significantly reduce the incidence of respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, and death in neonates without increasing the risk for infection in either the mothers or the newborns. The National Institute of Health recommends for all women at risk for preterm birth to get a dose of betamethasone. It's administered between 24 and 34 weeks. So typically after 34 weeks, we don't give the mom betamethasone. Usually it's a single course, and we usually give it 12 to 24 hours apart. Now, we have to be careful in our moms who are diabetic, because we know that steroids or glucocorticoids will raise the blood sugar. So we may have to cover the mom with insulin if her blood sugars really start to get high on us. Management of inevitable preterm birth. When preterm birth appears inevitable, magnesium sulfate may be administered to reduce or prevent neonatal neurologic morbidity. Current recommendations are that magnesium sulfate for neuroprotection be given to women who are at least 24 but less than 32 weeks of gestation at the time birth is expected to occur. Labor that has progressed to a cervical dilation of 4 centimeters or more is likely to lead to inevitable preterm birth. If birth appears imminent, preparations to care for a small immature neonate should be made. Women in preterm labor may rapidly progress to birth, and a very small fetus may be born through a partially dilated cervix. Also, malpresentation occurs much more frequently in preterm than in term fetuses. Therefore, nurses must be prepared to handle the emergency birth of a preterm infant from either cephalic or breech presentation without the woman's primary health care provider being present. Personnel skilled at neonatal resuscitation should be present at the time of birth. Equipment, supplies, and medications used for neonatal resuscitation should be gathered in advance and prepared for immediate use. If fetal or early neonatal death is expected, the parents and members of the healthcare team need to discuss the situation before the birth and decide on a management plan that is acceptable to everyone. Despite counseling about the likelihood of poor outcomes, some parents want everything possible, including cesarean birth for an abnormal fetal heart rate tracing, to be done for the baby. If such intervention is not desired, we usually don't even place the mom on the fetal heart rate monitor. Usually we may just put the Toco to check for contractions. But as an OB nurse, the labor and delivery nurse, you have to be prepared to catch babies because sometimes the physicians don't have time to get there. Even when I worked in a big teaching facility, I caught many babies because they would come in halfway out, and if the resident wasn't there waiting, or somewhere within a foot or two distance, they would even miss the birth. So most labor and I'll say all labor and delivery nurses, we also are trained for emergency deliveries. All right, premature rupture of membranes, or PROM, is the spontaneous rupture of the amniotic sac and leakage of amniotic fluid beginning before the onset of labor at any gestational age. Membranes that rupture at less than 37 weeks is responsible for 1/3 of all preterm births. And on this slide, this is a picture of the nitrazine paper. And typically when the mom's water has broken and we test the fluid will turn the paper this nice blue because the amniotic fluid is more alkaline. So usually this is one of the tests we do to see if the water is broken, and this is the nitrazine test. Another test that we do to see if the water is broken is ferning. And with ferning, you take a sample of the fluid, you place it on a microscope slide, you let it dry, and then you look under the microscope, and there should be pattern that we call ferns. They call it ferning because they say it looks like a fern leaf, but to me they look like little snowflakes. So we have the nitrazine, we have the ferning, and then the third test we do to see if the water is broken is a speculum exam. So the nurse or the physician or midwife will place a speculum into the vagina, and we'll usually ask the woman to give us a big cough, and we'll look and see if there's actually fluid coming out of the cervix. Preterm premature rupture of membranes, also known as PPROM, is when the membranes rupture before the completion of 37 weeks of gestation. It is associated with approximately 10% of all births in the United States. PPROM occurs twice as often in African Americans as in other racial groups. The frequency of PPROM appears to have decreased over the past decade. PPROM most likely results from pathologic weakening of the amniotic membranes caused by inflammation, stress from uterine contractions, or other risk factors that cause increased intrauterine pressure. Infection of the urogenital tract is a major risk factor associated with PPROM. The management of premature rupture of membranes is determined for each woman based on an assessment of the estimated risk for maternal, fetal, and neonatal complications if pregnancy is allowed to continue or immediate labor and birth are attempted. At term, because infection is the greatest maternal, fetal, and neonatal risk, birth is the best option. Labor will most likely be induced if it does not begin spontaneous soon after premature rupture of membranes occurs. Now, when we're talking about PPROM or preterm premature rupture of membranes, which occurs at or after 23 weeks of gestation and before 37 weeks, so between 23 and 37 weeks, this is often managed expectantly or conservatively if the risks to the fetus and newborn associated with preterm birth are considered to be greater than the risk of infection. Women with PPROM are usually hospitalized for conservative management in an attempt to prolong the pregnancy and allow additional time for fetal maturation unless intrauterine infection, significant vaginal bleeding, placental abruption, advanced labor, or non-reassuring fetal assessments occur. So typically our moms who PPROM, they are admitted to the hospital. Usually they're placed on the antepartum unit, and we do what we call expectant management. We don't do anything to put them in labor, and we usually won't do anything to stop labor if labor does start. Typically, these moms are in the hospital. We give them their course of steroids. They're placed on antibiotics. We give them their prenatal vitamin, their usual meds. Usually, we either have them on Lovenox or heparin because more than likely they're on bed rest. And what we usually do is just watch the mom. And if she goes into labor on her own, we usually just let the labor progress. Or if the mom looks like she's becoming infected, we usually will opt to deliver the baby if the mom becomes infected. And usually we will follow the SED rate, the sedimentation rate, to see if inflammation or infection is occurring. Chorioamnionitis. This is a bacterial infection of the amniotic cavity. It is a major cause of complications for both mothers and newborns at any gestational age. It occurs in approximately 1 to 5% of term births, but in as many as 25% of preterm births. Other terms for this condition include clinical chorioamnionitis, amnionitis, intrapartum infection, amniotic fluid infection, and intraamniotic infection. Chorioamnionitis is usually diagnosed by the clinical findings of maternal fever, maternal and fetal tachycardia, uterine tenderness, and foul odor of the amniotic fluid. Chorioamnionitis most often occurs after membranes rupture or labor begins, as organisms that are part of the normal vaginal flora ascend into the amniotic cavity. Many of the risk factors for chorioamnionitis are associated with a long labor, such as prolonged membrane rupture, multiple vaginal examinations, and use of internal fetal heart rate and contraction monitoring modes. Postterm pregnancy. A postterm pregnancy, also sometimes referred to as post-dates or prolonged pregnancy, is one that extends beyond the end of 42 weeks of gestation or 294 days from the first day of the last menstrual period. Maternal risks are often related to dysfunctional labor, such as increased risk for perineal injury related to fetal macrosomia. Risk for hemorrhage and infection is higher. Interventions such as induction of labor with prostaglandins or oxytocin, forceps or vacuum assisted birth, and cesarean birth are more likely to be necessary. We also worry about the mom's psychologic reactions because usually When pregnancies go past 40 weeks, 41 weeks, 42 weeks, these moms are tired and they are sick and tired of being pregnant. Not only do we worry about their psychological reaction, we also worry about the infant that's in utero, because the longer you go past 40 weeks, the older my placenta gets, and the older my placenta gets, the less likely it is to work efficiently. So not only is the mom suffering from being pregnant an extended period of time, the neonate, the infant inside the uterus, inside the mom, is also suffering because that placenta is old and it's not working as efficiently. Fetal risk for postdates. You can have abnormal fetal growth. You can have a baby who becomes macrosomic. I usually tell the mom, you're carrying a 2 week old or a 3 week old. So those babies can be big. Because of the macrosomia, that puts them at increased risk for birth injuries like shoulder dystocia, um, the aging of the placenta, which means it's not working as well, and also oligohydramnios, or low amounts of amniotic fluid. The management of post-term pregnancy is still controversial. However, because perinatal morbidity and mortality increase greatly after 42 weeks of gestation, pregnancies are usually not allowed to continue after this time. In the United States, most physicians induce labor at 41 weeks of gestation. An alternative approach is to initiate twice weekly fetal testing at 41 weeks of gestation. The testing generally consists of either a BPP, or biophysical profile, or a non-stress test, NST, along with an assessment of the amniotic fluid volume. Now we're going to focus on dysfunctional labor, or dystocia. Dysfunctional labor is defined as a long, difficult, or abnormal labor caused by various conditions associated with the 5 factors affecting labor. It is estimated that dysfunctional labor occurs in approximately 8 to 11% of all births, and it is the most common indication for a cesarean birth. Dystocia can be caused by any of the following factors: ineffective uterine contractions or maternal bearing down efforts, which is the powers; alterations in the pelvic structure or the passage; fetal causes including abnormal presentation or position, anomalies, excessive size and number of fetuses, that's the third P, which is the passenger; the maternal position during labor and birth; and then the psychologic responses of the mother to labor related to past experiences, her preparation, culture, and heritage, and her support system. Dysfunctional labor is expected when there is an alteration in the characteristics of uterine contractions, a lack of progress in the rate of cervical dilation, or a lack of progress in fetal descent and expulsion. Several factors that seem to increase a woman's risk for dysfunctional labor include obesity, or if the mom is overweight; short stature; advanced maternal age; infertility difficulties; prior version; uterine abnormalities; malpresentation and position of the fetus; CPD, or cephalopelvic disproportion, and basically that's the baby is too big to navigate through the mom's pelvis; uterine overstimulation with oxytocin; maternal fatigue, dehydration, and electrolyte balance and fear; and administration of an analgesic medication too early in labor, or use of continuous epidural anesthesia. The woman experiencing Dysfunctional uterine contractions, we have two categories. She could either experience hypertonic labor contractions or a hypotonic labor contraction pattern. So, for the woman experiencing hypertonic uterine dysfunction or primary dysfunctional labor, often is an anxious first time mother who is having painful and frequent contractions that are ineffective in causing cervical dilation or effacement to progress. Women with hypertonic uterine dysfunction may be exhausted and express concern about loss of control because of the intense pain they are experiencing and the lack of progression. Therapeutic rest is usually prescribed to manage hypertonic uterine dysfunction. And if we have a mom who's on Pitocin or oxytocin, one of the things we can do if she's having a hypertonic labor pattern is we can turn the Pitocin off or decrease the rate of the Pitocin. The second and more common type of uterine dysfunction is hypotonic uterine dysfunction or secondary uterine inertia. The woman initially makes normal progress into the active phase of the first stage of labor, but then the contractions become weak and inefficient or stop altogether. The uterus is easily indented even at the peak of contractions. Intrauterine pressure during the contraction is insufficient for progression of cervical effacement and dilation. Cephalopelvic disproportion and malposition are common causes of this type of uterine dysfunction. A woman with hypotonic uterine dysfunction may become exhausted and be at increased risk for infection. Management usually consists of ruling out CPD or cephalopelvic disproportion and assessing the fetal heart rate and pattern. Characteristics of the amniotic fluid if the membranes are ruptured, and maternal well-being. An intrauterine pressure catheter may be inserted to evaluate uterine activity accurately. Remember, I said the IUPC is the only way we can measure the true intensity of the contraction. If the findings are normal, labor augmentation measures may be implemented, such as ambulating the mom, breaking her bag of water, nipple stimulation, or my favorite, starting her on a Pitocin drip. So if she's not contracting enough to cause cervical change, we can augment the labor and put the mom on Pitocin to help increase the intensity, frequency, and duration of the contraction. This illustration is showing the uterine contractility pattern in labor. Now, A is your typical normal labor pattern, and what we consider a good labor pattern is contractions every 2 to 3 minutes, lasting 60 to 90 seconds. So this is what the contraction pattern should look like. Now, B is subnormal intensity. These aren't really what we call contractions. This is more like uterine irritability. I call them crampies. They're just not effective for to cause cervical change and dilation and effacement. C, these are normal contractions, but they're too infrequent for efficient labor. So this would be kind of your hypotonic. The mom is just not contracting enough. This is also D is incoordinate activity. She's having a contraction here, but she's really not doing too much else with the contraction pattern. And then E is your hypercontractility or your hypertonic contraction pattern, where you see the mom is just contracting too much. And this is also a pattern that's inefficient in causing cervical dilation. All right, the secondary powers or bearing down efforts are compromised when large amounts of analgesic medications are given. Anesthesia may also block the bearing down reflex and as a result alter the effectiveness of voluntary bearing down efforts. Exhaustion resulting from lack of sleep or long labor, and fatigue resulting from inadequate hydration and food intake reduce the effectiveness of the woman's voluntary bearing down efforts. Maternal position can work against the forces of gravity and decrease the strength and efficiency of the contraction. Table 17-1 in your book summarizes the characteristics of dysfunctional labor, so make sure you look over that table. Six abnormal labor patterns were identified and classified by Friedman according to the nature of the cervical dilation and fetal descent. These patterns are 1. Prolonged latent phase, 2. Protracted active phase of dilation, 3. Secondary arrest, 4. Protracted descent, 5. Arrestive descent, and 6. Failure of descent. Table 17-2 further describe these abnormal labor patterns. These patterns may result from a variety of causes, including ineffective uterine contractions, pelvic contractures, cephalopelvic disproportion, abnormal fetal presentation or position, early use of analgesics, nerve block analgesia or anesthesia, and anxiety and stress. Progress in either the first or the second stage of labor can be protracted or prolonged, or arrested or stopped. Precipitous labor. Precipitous labor is defined as labor that lasts less than 3 hours from the onset of contractions to the time of birth. This abnormal labor pattern occurs in approximately 2% of all births in the United States. Precipitous birth alone is usually not associated with significant maternal or infant morbidity or mortality. Precipitous labor may result from hypertonic uterine contractions that are tetanic in intensity. Conditions often associated with this type of uterine contractions include placental abruption, uterine tachycystole, and recent cocaine use. Maternal complications can include uterine rupture, lacerations of the birth canal, amniotic fluid embolus, and postpartum hemorrhage. Fetal complications include shoulder dystocia, hypoxia caused by decreased periods of uterine relaxation between contractions, and in rare instances, intracranial trauma related to rapid birth. And a lot of your babies who moms deliver precipitously, they usually will have some facial bruising because of the rapid descent through the vaginal canal. Obesity. Obese women are likely to begin pregnancy with pre-existing medical conditions such as chronic hypertension and type 2 diabetes. While pregnant, they may develop pregnancy-associated hypertensive disorders, or gestational diabetes may be diagnosed. Obese women also have an increased incidence of post-dates pregnancy. All of these risk factors make them more likely to undergo labor induction. In addition to an increased risk for cesarean birth in general, obese women are also more likely to require emergency cesarean birth. Nursing care of obese women during labor and birth is challenging for a number of reasons. Sometimes standard furniture such as beds, chairs, and operating tables is simply not large enough to accommodate the woman's size. Continuous external fetal heart rate monitoring and contraction monitoring may be extremely difficult, if not impossible, to perform, especially if we're trying to do external monitoring. It can be very difficult on an obese woman. So usually once they break her water, we would put internal monitors such as an FSC and an IUPC so we can accurately record the baby's heart rate and the mother's contraction pattern. Now we're going to go into different obstetric procedures that you may see on labor and delivery. We're going to talk about the version first. A version is the turning of the fetus from one presentation to another. It may be performed externally or internally by the physician. Typically, what you're going to see most likely is the external cephalic version. It is used in an attempt to turn the fetus from a breech or shoulder presentation to a vertex presentation for birth. It may be attempted in a labor and birth setting after 37 weeks of gestation. External cephalic version is accomplished by the exertion of gentle, constant pressure on the abdomen. Before ECV is attempted, ultrasound scanning is done to determine the position of the fetus, to locate where the umbilical cord is, to rule out placenta previa, and to evaluate the adequacy of the maternal pelvis, and to assess the amount of amniotic fluid, the gestational age, and the presence of any anomalies on the fetus. Typically, before we do the external cephalic version, we will do an NST to confirm fetal well-being. We'll look at the heart rate. We'll look at the monitor to make sure the mom is not contracting. We will get informed consent for the procedure. Usually they'll give the mom a tocolytic agent such as terbutaline to relax the uterus so that she won't start contracting. Next, we go to induction of labor. The induction of labor is the chemical or mechanical initiation of uterine contractions before their spontaneous onset for the purpose of bringing about birth. Labor may be induced either electively or for indicated reasons. Induction of labor is one of the most commonly performed obstetrical procedures in the United States. An elective induction is one in which labor is initiated without a medical indication. Methods to ripen the cervix enhances the likelihood of successful induction. Success rates for induction of labor are higher when the condition of the cervix is favorable or inducible. Cervical ripeness is the most important predictor of successful induction. A rating system such as the Bishop score, and you can look at table 17-3, can be used to evaluate inducibility. So, for example, a score of 8 or more on this 13-point scale indicates that the cervix is soft, anterior, 50% or more effaced, and dilated 2 centimeters or more, and that the presenting part is engaged. When the Bishop score totals 8 or more, induction of labor is usually successful. The Bishop score should be documented before the use of methods to ripen the cervix or induce labor. So when we're inducing labor, basically in order for labor induction to be successful, we have to have what we call a favorable cervix, a ripened cervix, because if the cervix is not favorable, induction won't work. So typically what we can do, we can bring the mom in the night before, and we can use some cervical ripening agents. Those agents we use include Cytotec, Cervidil, or Prostin gels. So we can use any of those to help soften the cervix, because once the cervix is soft, it typically will start to open easier. So once we get the cervix nice and soft and to open a little bit, then we can go about with the inducing the labor. This is figure 17-6 in your book, the external version of the fetus from breech to vertex presentation. This must be achieved without force. In figure A, you can see a breech is pushed up out of the pelvic inlet while the head is pulled toward the inlet. And B, the head is pushed toward the inlet while the breech is pulled upward. So typically if we bring a mom in for a version, if the version is successful, so if the baby goes from a breech presentation to a vertex presentation, we usually will induce the mom's labor because the likelihood of the baby going back to a breech is quite high. Or if the version is unsuccessful, where we can't get the baby to go from breech to vertex, we will then probably just bring the mom back in later for a scheduled C-section. All right, cervical ripening methods. I started talking about this a little bit, but now we're going to really go into it. Preparations of prostaglandins have been shown to be effective when used before induction to ripen, which is to soften and thin the cervix. Um, we have what we call the cervidil. And usually, like I said, we bring the moms in the night before. We will put the cervidil in the posterior fornix of the vagina, right against the cervix, and we let the cervidil sit there. And typically, the next morning, we will remove the cervidil and see if the cervix is favorable or soft. Then we would use our Bishop score to see if we have a favorable cervix. The good thing, or the nice thing with the cervidil, I tell people it looks like, I say, like a mini tampon. It's a very little piece of where the medication is that's attached to a string. So the good thing with the cervidil is if the mom starts contracting too much, we can just pull the cervidil out. Um, some mechanical dilators. They ripen the cervix by stimulating the release of endogenous prostaglandins. Your book talks about the balloon catheters. Basically, it's just a Foley catheter, but typically the balloon, your normal Foley catheters only hold 10 mLs of fluid, and with the Foley catheters that we use for um, cervical ripening, you can get up to 25 to 50 mLs of fluid in them. It can be inserted through the intracervical canal to ripen and dilate the cervix. The catheter balloon is inflated above the internal cervical os with 30 to 50 mLs of sterile water. This process results in pressure and stretching of the lower uterine segment and the cervix, as well as the release of endogenous prostaglandins. So typically, we'll bring the mom in, we'll insert the Foley catheter, and typically, usually when the Foley catheter falls out, typically the mom is anywhere between 3 and 4 centimeters dilated. Another mechanical dilator we have is laminaria. We don't use laminaria that much in cervical ripening for labor, but they do use laminaria quite a bit when they're doing induced or elective abortions. But what laminaria is a natural cervical dilator made from desiccated seaweed. Um, and it contains synthetic dilators containing magnesium sulfate. They're inserted into the cervix, and the water bag isn't broken. As they absorb fluid from the cervix and the vagina, they expand and cause cervical dilation and the release of endogenous prostaglandins. Typically, we leave them in place for 6 to 12 hours before being removed to assess cervical dilation. So usually your laminaria, they start out, they look like little twigs, and you kind of place as many as you can into the cervix. Usually we do between 6 and 8. It depends on, how, if the cervix is dilated any. But usually they put about 6 or 8 laminaria, and like I said, once it starts absorbing fluid from the surrounding tissue, they start to swell, and that causes the cervix to open up and dilate. Amniotic membrane stripping is a method of inducing labor through the release of prostaglandins and oxytocin. And if anyone who's had a baby has ever had their membrane stripped, this is something they will never forget because it can be quite uncomfortable. So basically what happens is the female goes to see her OBGYN or midwife, and they do a, I call it a very aggressive cervical exam, but basically they take their fingers and they separate the bag around the baby from the cervix. And sometimes this is enough to simulate contractions and put the moms into labor. Amniotomy is the artificial rupture of membranes, which we call AROM. It can be used to induce labor when the condition of the cervix is favorable, or if the mom is already in labor and the labor is starting to slow down, we can break her bag of water to augment labor, because typically once the bag of water is broken, the contractions usually start coming closer together and getting stronger. Oxytocin, good old vitamin P. Oxytocin is a hormone normally produced by the posterior pituitary gland. It stimulates uterine contraction and aids in milk letdown. Synthetic oxytocin or pitocin may be used either to induce labor or to augment a labor that is progressing slowly because of inadequate uterine contractions. Oxytocin is used in the majority of all births in the United States. It is also the drug most commonly associated with adverse events during childbirth. The most common errors involving oxytocin administration during labor are dose related. So, as the labor and delivery nurse, our goal is to get the mom in a contraction pattern of contracting every 2 to 3 minutes, lasting 60 to 90 seconds. So, what we do is we titrate our pitocin. So, there's different protocols for how it is administered, but typically, most places you can do one every 15 minutes or 2 milliunits every 30 minutes. Now, some places have high dose protocols, some have low dose protocols. It kind of depends on the physician, but your goal with the Pitocin is to get the mom into a good labor pattern, and that's contracting every 2 to 3 minutes, lasting 60 to 90 seconds. Oxytocin use can present hazards to the mother and fetus. Maternal hazards include placental abruption, uterine rupture, unnecessary cesarean birth because of abnormal fetal heart rate and patterns, postpartum hemorrhage, and infection. When placental perfusion is diminished by contractions that are too frequent or prolonged, the fetus can experience hypoxemia and acidemia, which eventually results in late decelerations and minimal or absent baseline variability. The goal of oxytocin use is to produce contractions of normal intensity, duration, and frequency while using the lowest dose of medication possible. So you have to know how to control your pitocin. All right, now we're going to talk about operative vaginal births. Operative vaginal births are performed using either forceps or a vacuum extractor. The use of both devices continued to decline, and in 2010, fewer than 4% of all births were accomplished using forceps or vacuum assistance. So, a forceps assisted birth is one in which an instrument with two curved blades is used to assist in the birth of the fetal head. Maternal indications for forceps assisted birth includes a prolonged second stage of labor and the need to shorten the second stage of labor for maternal reasons. Fetal indications include an abnormal fetal heart rate tracing or certain abnormal presentations, arrest of rotation, or extraction of the head in a breech presentation. And this is figure 17-9. This is showing the use of forceps, outlet forceps assisted extraction of the head. Now, when we're using forceps, we want to make sure that the head is very low. You don't want to use high forceps, because if the baby is indeed macrosomic, It can cause a shoulder dystocia. And also, if you notice, a lot of babies that are delivered via forceps, they may have some eye damage, so they may have palsy of their eyes because of how the blades are placed. Very seldom will you see forceps being used nowadays because of the vacuum. The vacuum has fewer side effects, such as the palsy around the eye or any head damage. But these are some different types of forceps. And in my training, or when I worked as an L&D nurse, there was like two doctors, our perinatologists, that would use forceps, and they would only use it to teach the resident doctors how to properly place them on. But very rarely will you see forceps delivery because we have the vacuums. All right, a vacuum assisted birth or vacuum extraction is a birth method involving the attachment of a vacuum cup to the fetal head using negative pressure to assist in the birth of the head. It is generally not used to assist birth before 34 weeks of gestation. We don't use it on preemies because they already are at greater risk of having intraventricular hemorrhage in the brain. So the last thing we want to do is put a vacuum on a preemie. Indications for its use are the same as those for outlet forceps. The prerequisites for use include a completely dilated cervix, ruptured membranes, an engaged head, vertex presentation, and no suspicion of cephalopelvic disproportion. Risk to the newborn includes cephalohematoma, scalp lacerations, and subdural hematoma. And this is figure 17-10 in your book, the use of a vacuum extraction to rotate the fetal head and assist with descent. So here you can see the baby's in an OP position. Now they got it into an OT and finally to an OA, an occiput anterior. And then B is the caput succedaneum formed by the vacuum cup. And we'll talk more about caput versus cephalohematoma when we get into the newborn. Cesarean birth. Cesarean birth is the birth of a fetus through a transabdominal incision of the uterus. Whether cesarean birth is planned or unplanned, the loss of the experience of giving birth to a child in the traditional manner may have a negative effect on a woman's self-concept. An effort is therefore made to maintain the focus on the birth of the baby rather than on the operative procedure. So some indications for a cesarean delivery: if the mom has been diagnosed with complete placenta previa, cephalopelvic disproportion, placental abruption, if she has an active herpes outbreak at the time of labor, if there's a cord prolapse, FTP is failure to progress, if there are non-reassuring fetal heart tones, if the mom has had a previous classical C-section, if there are tumors that obstruct the birth canal. The different type of surgical techniques. When we're talking about C-sections, we really are interested in the scar that is on the uterus, not the scar that is on the skin. So typically, if the mom has had a classical C-section, there's going to be a vertical scar on her uterus. Once a mom has had a classical C-section, she always has to be delivered via a C-section. Typically, moms who've had C-sections for preemies, because we can't cut the lower uterine segment because it hasn't developed well enough, those moms tend to have classical C-sections. And then moms from other countries, especially from South American countries, they typically all, we just assume that the scar on their uterus is a classical or a vertical scar. We know with C-section, maternal morbidity and mortality increases, and you have to treat moms who've had C-sections just like any other person who has had major surgery, because a C-section is major abdominal surgery. This is figure 17-11. These are the skin incisions. Like I said, we don't really care about the incision on the skin. What I want to know is what type of incision is on the uterus. So that's a vertical or classical. There's another classical. This is what we're looking for. We usually do a low transverse. So if they've had this kind of C-section, a low transverse, they may have the option to do a vaginal birth after cesarean. This is figure 17-12. It shows the uterine incisions for a cesarean birth. Um, A is a low transverse incision, B is a low vertical incision, and C is the classic incision. All right, intraoperative care. Basically, like in any surgery, when you have a mom who's going for a cesarean section, whether it's scheduled or if it's an unplanned, definitely you want it to disclosure of confidential information. You always have to think about your HIPAA. When you're in the operating room with the mother, we do what we call the time out. And I know you guys know this from your previous med surg experience in the operating room, but we do a surgical time out. We count the instruments. You usually have your scrub person, you have a circulating nurse, you have your physician, and usually they will also have an assistant. Immediate post-operative care, usually they will go to PACU, or some hospitals have it where they don't have a obstetrical PACU. They take the patient back to one of the labor rooms and they recover in the labor and delivery room. Just like for any surgery, when we take them to PACU, they're placed on the cardiac monitors. We're doing vital signs. Typically, for uh, the first 15 minutes, we're doing them every 5 minutes. Then we're doing them every 15 minutes. We're checking to make sure that the O2 sats are okay, that the mom's bleeding is under control. As we're doing vital signs, we're also assessing her fundus to make sure that her fundus is firm also. We give some pain medications, and typically we have them in PACU for about an hour, maybe 2 hours. And once they have met the criteria for discharge from PACU, we take them over to the postpartum unit. And again, on the postpartum unit, um, they do vital signs on admission, make sure that the mom is hemodynamically stable. They're going to check her fundus, they're going to check her bleeding, and typically within 12 to 24 hours, we are getting those moms up and starting them to ambulate. Safety alert, you want to monitor the patient closely as she may be drowsy and at risk for falling asleep while holding her baby. And typically, if the mom had a C section, we won't leave the baby in the room with the mom alone until the mom is able to ambulate. Typically, if the mom has a significant other or a family member in the room that can take care of the baby, I will leave the baby in there. But if the mom has no one in there and she's still not able to ambulate on her own, we will not leave the baby in the room. These are just pictures of a cesarean section. Hopefully everyone will at least get to see one during our labor and delivery rotation. The baby's out. They're getting ready to clamp and cut the cord. Okay, we're going to continue with obstetric procedures. We're going to talking about the VBAC, or the vaginal birth after cesarean section. Um, Basically, a mom who had a cesarean section that was not a classical cesarean, or if the mom had the C-section, if it wasn't, the C-section wasn't for reasons of cephalopelvic disproportion, that the baby was too big to fit through her pelvis. Um, Usually those moms, we don't offer VBAC. But if the mom had her cesarean section maybe for fetal distress, or just some other things, they may be allowed to have a vaginal birth after cesarean. So indications for primary cesarean birth, such as dystocia, breech presentation, or fetal distress, often are non-reoccurring. So these are moms who we would offer a VBAC to. Um, they may be a candidate to attempt a vaginal birth. The problem with VBACing, or having a vaginal birth after cesarean, is it's really hard to find a physician that will do a vaginal birth after cesarean. Typically, these women are considered high risk, so they are usually not delivered by midwives. Um, but it's very hard to find a physician who will do a VBAC. There are still some out there, but a lot choose not to. If they've had a mom who's had a C-section before, they either tell her she needs to have another C-section, or if she truly wants the VBAC, they sometimes will release them from the practice and the mom has to find another doctor. Trial of labor is the observance of a woman and her fetus for a reasonable period of spontaneous active labor to assess the safety of vaginal birth for the mother and the infant. It may be initiated if the mother's pelvis is of questionable size or shape, or if the fetus is in an abnormal presentation or position. By far, the most common reason for a trial of labor is the woman wishes to have a vaginal birth after a previous cesarean section. And typically, moms who VBAC, we try not to use Pitocin, because our fear is that the uterus is going to rupture at the site of that previous C-section scar, because the uterus is weak at that point. So typically these moms, they have to go into labor on their own. Usually we're going to put an IUPC in to make sure that the pressure inside the uterus is not too great of a pressure. And typically we don't start these moms on Pitocin because we are fearful that uh, giving her Pitocin can cause that uterus just to contract too much, or that the intensity can be too great and the uterus will rupture at that old C-section scar site. The incidence of uterine rupture is 0.6% in women trying to VBAC. The risk of VBACing includes hemorrhage, rupture of the uterus. If the uterus ruptures and the mom bleeds too much, they may not be able to save the uterus. They may have to perform a hysterectomy. There could be surgical injuries. There could be infant death. And if the infant doesn't die, the infant can have neurologic complications such as cerebral palsy. Obstetric emergencies. First thing we're going to talk about is meconium stained amniotic fluid. When there's meconium in the amniotic fluid, it indicates that the fetus has passed meconium, or their first stool, before birth. Meconium stained amniotic fluid is green. The consistency of the amniotic fluid is often described as either thin or thick, depending on the amount of meconium present. Three possible reasons for the passage of meconium are: 1, it is a normal physiologic function that occurs with maturity. um, or with a breech presentation. It is the result of hypoxia induced peristalsis and sphincter relaxation, or it may be a sequel to umbilical cord compression induced vagal stimulation in mature fetuses. The major risk associated with meconium same amniotic fluid is the development of meconium aspiration syndrome in the newborn. Meconium aspiration syndrome causes a severe form of aspiration pneumonia that occurs most often in term or postterm infants who have passed meconium in utero. So typically, when we have a mom and we break their water and there is meconium present, we usually will have a team present at birth, maybe someone from nursery or the neonatologist. Usually, when these babies are born, we don't stimulate them to breathe because we don't want them to take that big gasp of air and swallow that meconium and it gets into their lungs. So, typically, we try not to stimulate them. We take them over to the warmer, we intubate them, look below the cords, make sure there's no meconium below the cords, and do a deep suction. And usually, after you do that, the baby will come around and start to cry. All right, shoulder dystocia. If you remember the ER film I showed you with Mark and his shoulder dystocia, so think of that when we were talking about shoulder dystocia. It is a condition in which the head is born, but the anterior shoulder cannot pass under the pubic arch. It is estimated that 0.6 to 1.4% of all vaginal births are complicated by shoulder dystocia. Fetal pelvic disproportion related to excessive fetal size. You have a fetus that's 4,000 grams or more, or maternal pelvic abnormalities may be a cause of shoulder dystocia, although up to half of all cases of shoulder dystocia occur with small fetuses. Other risk factors for shoulder dystocia include maternal diabetes and a history of shoulder dystocia with a previous pregnancy. The newborn is most likely to experience birth injuries if we can't get that shoulder out. Sometimes the clavicle has to be broken, and sometimes, if there's a lot of pressure placed on that shoulder, they can develop a palsy in that shoulder. The mother's primary risk stems from excessive blood loss, lacerations, extension of episiotomy. We have to make more room in order to try and get that baby out. All right, this is figure 17-15. This is showing the application of suprapubic pressure. You want to make sure that you do suprapubic pressure and not fundal pressure. I don't want pressure up here. I want pressure right over that symphysis pubis bone so that I can get some extra room to get this shoulder out. All right, this is figure 17-6. This is McRoberts maneuver. With the McRoberts maneuver, the woman's legs are flexed apart with her knees on her abdomen. This maneuver causes the sacrum to straighten and the symphysis pubis to rotate towards the mother's head. The angle of pelvic inclination is decreased, which frees the shoulder. Suprapubic pressure can also be applied once you get the moms in McRoberts position. The McRoberts maneuver is the preferred method when a woman is receiving epidural anesthesia. When we're talking about shoulder dystocia, newborn assessment should include examination for a fracture of the clavicle or humerus, as well as brachial plexus injuries and asphyxia. Maternal assessment should focus on early detection of hemorrhage and trauma to the vagina, perineum, and rectum. All right, prolapse umbilical cord. This occurs when the cord lies below the presenting part of the fetus. This is a true emergency in the OB world. Contributing factors include a long cord, a malpresentation if the baby's breech or transverse, or an unengaged presenting part. That's why we never break water unless the head is fully engaged, because there's always a chance that once you release that fluid, the cord is going to fall right out with it. Pressure on the cord may be relieved by the examiner putting a sterile gloved hand into the vagina and holding the presenting part off the umbilical cord. The woman may also be assisted into a position such as a modified Sims, Trendelenburg, or knee chest position, in which gravity keeps the pressure of the presenting part off the cord. Okay, this is figure 17-17 in your textbook, and it's showing prolapse of the umbilical cord. In A, you have an occult or hidden prolapse of the cord. B, you have a complete prolapse of the cord. C, you have the cord presenting in front of the fetal head. It may be seen in the vagina. And then D, you have a frank breech presentation with the prolapse cord. All right, this is figure 17-18. The arrows indicate direction of pressure against the presenting part to relieve compression of the prolapsed umbilical cord. Here in figure A, you have a baby that's vertex, so the examiner is pushing up on the head to relieve the pressure off the cord. And here you have a baby that's in the breech presentation, and the examiner is pushing the baby's buttocks up off of the cord. This is showing the different positions you can put the moms in. This is the modified Sims. This is the knee chest. But like I was saying in class, if they have epidurals, it's kind of hard to get them in knee chest. So the easiest position maybe is to put them in Trendelenburg. But once you have a prolapsed cord, this is an emergency C-section. And like I said, your hand or the examiner's hand is in there in the vagina holding pressure off of the cord by pushing up on the presenting part, and you will go down the hall to the operating room, and typically your hand cannot come out of the vagina until the physician has delivered the baby. So this can be quite a roller coaster of events. And typically when you're the one who feels a cord, you don't take your hands out to go say, I have a prolapsed cord. You keep your hands in there and you scream for help. All right, rupture of the uterus. Rupture of the uterus, in which there is a complete non-surgical disruption of all uterine layers, is a rare but very serious obstetric injury that occurs in 1 in 2,000 births. During labor and birth, the major risk factor for uterine rupture is a scarred uterus as a result of previous cesarean birth or other uterine surgery. Rupture usually occurs during a trial of labor for VBAC, or vaginal birth after cesarean. Symptomatic rupture is rarely observed in planned repeat cesarean births. The likelihood of uterine rupture varies depending on the type and location of the previous uterine incision. Uterine rupture occurs most often with a previous classic cesarean section. Signs and symptoms vary with the extent of the uterine rupture. The most common finding is an abnormal fetal heart rate tracing, particularly variable or prolonged decelerations or bradycardia. A loss of fetal station may also occur. The woman may experience constant abdominal pain, uterine tenderness, a change in uterine shape, and cessation of contractions. She may also exhibit signs of hypovolemic shock caused by hemorrhage, such as hypotension, tachypnea, pallor, and cool, clammy skin. If the placenta separates, the fetal heart rate will be absent. Fetal parts may also be palpable through the abdomen. During labor and birth, rupture of the uterus may be caused by intense spontaneous uterine contractions, labor stimulation with oxytocin or prostaglandins, an overdistended uterus, such as with multifetal gestation, your twins, triplets, quads, malpresentation, external or internal version, difficult forceps assisted birth. You see it more often in your multigravidas than your primogravidas. Women who've had multiple cesarean births. Women who've had cesarean sections and they've had augmented or induced labor. Macrosomia, infection, and short intervals between pregnancies. So these are all common things that may cause the uterus to rupture. Okay, question. A client is to have an amniotomy to induce labor. The nurse recognizes that the priority intervention after the amniotomy is to A. Apply clean linens under the woman, B. Take the client's vital signs, C. Perform a vaginal examination, or D. Assess the fetal heart rate. The answer is D. This concludes the audio lecture for Chapter 17, Labor and Birth Complications. Thank you.